Hello, welcome everyone to the PrecisCa Lung Cancer Tumor Board. I want to welcome all our panelists today. I am Ramaswamy Govindan, a medical oncologist at Washington University in St. Louis. I'm joined today by our experts. We'll start out with the introductions. Dr. Ginsberg.
Hi, I'm Michelle Ginsberg. I'm Director of Cardiothoracic Imaging and Vice Chair for Education at Memorial Sloan Kettering Cancer Center and Professor of Radiology at Weill Cornell Medical College.
I'm Larry Keston. I'm a radiation oncologist in the Detroit, Michigan area for Michigan Healthcare Professionals and Genesis Care USA Medical Director in Michigan.
I'm Tom Stinchcomb. I'm a medical oncologist who specializes in thoracic oncology at Duke University in Durham, North Carolina.
Hello, I'm Dr. Seth Force. I'm the Kamal A. Mansour Professor of Surgery and Chief of General Thoracic Surgery at Emory University Hospital in Atlanta, Georgia.
This is a 77-year-old male with a history of smoking and a stage 4 epithelioid mesothelioma, presented with shortness of breath and pain in the chest wall, and had a performance status of 2. Medical history was significant for chronic obstructive lung disease and a remote history of prostate cancer treated with curative prostatectomy, and has 20-pack history of tobacco smoking with moderate alcohol abuse. The family history is notable for the daughter with breast cancer and the father with a history of prostate cancer. Dr. Ginsberg, do you want to comment on the CT scan?
This is a pretty typical appearance for mesothelioma, where we see this circumferential pleural-based mass, which often will invade the pleura along the fissures as well. And we see volume loss in the right lung, which is also a very typical appearance with sort of a constrictive appearance of the lung. In addition, in this patient, unfortunately, there are bilobar hepatic metastases and bilateral pulmonary nodules. No lymphadenopathy seen in these images.
Thank you. So this patient underwent pleural biopsy consistent with malignant mesothelioma favoring epithelioid type, positive for mesothelial markers, including calretinin, WT1, podophyllin, and pancytokeratin. This patient was treated with carboplatin pemetrexed for 4 cycles, followed by maintenance pemetrexed beginning June of 2018. 5 months later, the CT scan showed some findings. And Dr. Ginsberg, please.
We see further increase in the pleural thickening circumferentially. And in addition, we see these 2 nodules in the right upper lobe, which are new compared to the baseline study. We don't have sections of the liver, but the liver supposedly demonstrated a decrease in the bilobar metastases.
Thank you. And this patient received palliative radiation therapy, 20 gray in 5 fractions to the right hemithorax, and the pain improved slowly. And the question is, how would you manage this patient? So Dr. Stinchcomb, very provocatively, would you change therapy at this point, or would you just watch these lesions? After all, they are growing slowly, and what would you do?
So a difficult question. I think we depends on the patient's performance status and wishes. I think you could do surveillance. I think the other option I would talk to them is about single agent immunotherapy. You know, we know from a phase 3 trial, immunotherapy had a higher response rate, but very similar progression-free survival and overall survival to chemotherapy, single agent chemotherapy. And then I think if this is a very good performance status, I would discuss nivolumab and ipilimumab. I realize that this is sort of dangerous territory. But I think the question really for me would become, we know that nivo and ipilimumab is a better first-line therapy than carboplatin and pemetrexed. And extrapolating from that first-line trial to the second-line setting, which admittedly is dangerous, the question would be, should we do the nivo ipilimumab, which had demonstrated a higher response rate than what we observed in the single-agent immunotherapy trials to date?
Those are all good questions, and we don't have a good option for patients who progress following the frontline therapy, right? We have best data in the frontline therapy. We have established data on pemetrexed and cisplatin, carboplatin, Of course, our good friend Giorgio Scagliotti did those studies earlier on, and then the more recent randomized studies you referenced to nivo-ipi compared to chemotherapy. My reading on that was, even though the trial favored the combination of immunotherapy, the benefit was seen mostly in the sarcomatoid subtype rather than the epithelioid subtype. Again, the studies were done, including both the types. And any comments on that? Do you change your systemic therapy to begin with? We'll talk about this patient in a second. Do you change your therapy for frontline, in the frontline setting, based on the histological subtype, if they are deemed not to be resectable or appropriate candidates for definitive radiation therapy?
I have used nivo-ipi, and regardless of the histology, because I think the intent to treat was positive. I agree the benefit was more modest in epithelioid and a little bit more dramatic in the sarcomoid subtype. But if you really look at those Kaplan-Meier curves, it's because the sarcomoid subtype did so poorly with chemotherapy that I think the hazard ratio looked dramatically bigger in that situation, but it was really the underperformance of the standard therapy in the sarcomoid subtype. I think that this is a very difficult disease because many times when I've seen these patients, you often only have one chance to intervene in the disease because sometimes these can be dramatic and the patient can symptomatically deteriorate, so I think that is my thinking.
Yeah. For newly diagnosed mesothelioma patients, Dr. Force, when is surgery an option?
So surgery being an option for patients with early stage disease, I guess a way to answer the question is who isn't a candidate. So patients with advanced stage mesothelioma, stage 3 or 4, really, we know that the survival when we compare it to even lung cancer is so much poorer. So those patients really don't benefit from surgery. And that would include mediastinal nodal disease. Those patients, really, they recur and they don't benefit from surgery. And also the sarcomatoid variant, as you brought up, those patients do so poorly that surgery does not seem to really positively affect their long-term survival. It's a massive operation. There's two surgical options: an extrapleural pneumonectomy, which is a really huge operation that's got its litany of morbidity and risk, or a radical pleurectomy. And they have their pros and cons, but because of the overall poor survival, we really think twice before we would operate on someone, and we want to make sure that they have epithelioid type and early stage cancer.
Terrific, thank you. There is a case often made, even in patients with advanced mesothelioma who are clearly not candidates for extrapleural pneumonectomy, to do this, partial surgery. Just the pleurectomy. Would you favor that? Do you do that?
I don't like I don't favor the radical pleurectomy, although it's a well-established procedure, really championed at Dr. Ginsburg's hospital, Memorial Sloan Kettering, and the outcomes seem to be in some series equivalent to that for extrapleural pneumonectomy. I think the downsides are that when we look at the best overall survival for surgical candidates, it's with trimodality therapy. So that would include, often neoadjuvant chemotherapy followed by surgery, followed by hemithoracic radiation. It's hard to do the radiation, possible but hard, and maybe Dr. Keston can comment, with the lung still in there. With the lung out, there really is nothing to hit. And the problem with mesothelioma, it comes down to margin. So your margin is the depth of the pleura, which is basically paper thin. So we don't have margins. It's very difficult to get what we call R0 resections, or microscopically negative resections. And it's so diffuse. It goes all the way down to the diaphragm and all the way to the top of the chest, So, I think in my mind, if we really are going for a cure, we want maximally aggressive therapy, and that would involve that trimodality therapy, including adjuvant radiation.
Thank you. Dr. Keston, do you want to comment on the role of radiation therapy in mesothelioma?
Certainly, Dr. Govindan. Primarily, radiation treatment for malignant mesothelioma is used for palliative circumstances. local treatment of a particular problem. Obviously, this patient had some palliative radiation treatment. If we choose to take an aggressive approach like Dr. Force or Dr. Stinchcomb mentioned, for an earlier stage patient, then neoadjuvant systemic therapy, followed by surgery, which could be extracorporeal pneumonectomy, or I guess pleurectomy decortication is a newer technique that has been used, followed by postoperative radiation treatment. As Dr. Forrest indicated, it would be far too toxic to deliver radiation treatment while the lung is in place, because one has to treat the pleura around it without treating the lung, which is basically impossible to do in a satisfactory manner. So we have to, if we're going to add radiation treatment, we have to do it in a postoperative manner. Even then, the postoperative radiation treatment course I mean, these patients have been through quite a bit up to that point, and the radiation treatment is not, it's hard on patients. I mean, you need a patient who's really, has a good performance status, doing well after surgery. And then I would typically use a very, complicated planning technique, with IMRT for the pleura, which is, it's a very difficult process. This is typically handled in, tertiary centers or centers that have a high volume of these types of cases. I know there is a national trial right now that is looking at systemic therapy plus surgery, pleurectomy decortication, randomizing patients to a postoperative radiation treatment and following those procedures. But if you want to take an aggressive approach for an early stage case, which I have certainly done, it's a consideration.
Thank you. So to summarize our wonderful discussion for this patient who is progressing after pemetrexed, carboplatin, and maintenance pemetrexed, our recommendation is to consider systemic therapy with a single agent pembrolizumab or a combination of nivolumab and ipilimumab. We also discussed the role of immunotherapy, nivolumab, ipilimumab in the frontline setting of mesothelioma, which appears to be superior to chemotherapy. We also recognize that localized therapy like surgery or radiation treatment should be limited to those fit, strong individuals who have an excellent performance status, who have a potential for cure, should be done in specialized centers with considerable amount of expertise and multimodality management. Thank you very much.